Welcome to Focus on Seniors, a television show sponsored by Helping Seniors of Brevard County, Florida. The show is designed to make you aware of senior issues, needs, and resources available to help us age in place and with dignity. This show will help you as you develop your own aging and care plan.
I'm Joe Steckler. Welcome to Focus on Seniors, the television arm of Helping Seniors of Brevard County, a show designed to provide you with information on how to develop your own aging and care plans. Our topic today is osteoarthritis, and with me in the studio is Marco Bensimon, who is the physical therapist and rehabilitation director, and Nancy Deardorff, registered nurse and branch director. Both of them are from Gentiva Homecare of Melbourne. And today, the subject of osteoarthritis is something that we need to know more about it, and I feel we have two people here today that can certainly talk about it. Nancy, welcome, and thank you for coming here today.
Thank you. Good to be here, Joe.
Thank you. And Marco, thank you for coming on the show today.
Thank you so much, Joe.
And do you intend to grow a full handlebar mustache, or what are you going to do?
I'm not so sure yet.
Well, let me tell you. Sometimes I'm not going to show. I'll bring you my picture when I grew a full beard with a handlebar mustache that went all the way around. I grew it on a submarine patrol back in the early 60s, and we came into port in Pearl Harbor. When the admiral came down to the ship, the first thing he told us was, get rid of the berets and shave. So there went my 3-month beard in my effort.
I think, if I'm not mistaken, our friend is getting ready for a Halloween party coming up.
That's what it is.
Yes, and he wants to be authentic. So.
And that's what it is. Exactly.
Yes.
I'm not sure.
I think he wears it well.
He is impressive, and I'm not going to say what image it is now, but
thank you so much.
Okay, well, let's get back on osteoarthritis.
Yes,
okay?
Sir.
What is osteoarthritis? Marco, you.
Okay, well, osteoarthritis, also known as degenerative joint disease more commonly. It's a group of mechanical abnormalities involving degradation of the joints, including articular cartilage and subchondral bone. I'm being a little technical here. Mainly what I'm saying is it's the degeneration of the articular cartilage, the part of the cartilage that is inside the joint and articulates with the other, the subsequent bone right there. So that's pretty much what it is. It's degeneration of the cartilage.
Okay, say my knee. This is my knee right here.
Yes.
Top part, bottom part. In between is a cushion in there.
Yes.
That stuff goes away and you got a problem, right?
Yes. Concerning the knee, that's what you're referring to as the meniscus, which is also a cartilaginous piece, but osteoarthritis is more in reference of the last revestment of the bone, where the end of the bone. So that's where it occurs, very much so.
And when that happens, what do you feel?
You feel pain. There is usually inflammation. There is sometimes redness, and many times effusion or swelling.
Well, you're a home health care agency and you provide skilled nursing services. How do you all treat or help people that are recovering from osteoarthritis operations, or do you get involved before they have operations?
Both, and I think we have to clarify, you don't really recover from osteoarthritis unless you're talking about a joint replacement situation, which I'm going to default to Marco for that. But as far as the nursing aspect of that, many times we'll get a referral for a patient with a different disease process, something that is more nursing related, say heart failure, chronic obstructive pulmonary disease. But there are a lot of people out there, and I don't know the statistics, Marco, on people with osteoarthritis. So we'll find when we get out there as nurses that our patients are suffering from this, and as a result are suffering from a lot of pain. Well, the pain with motion with the disease of osteoarthritis creates a situation where people want to be more sedentary because they don't want to move, because oftentimes that exacerbates the pain.
I can understand.
So the key with the role of nursing right there is to identify that and recognize, and this is true when we're talking about physical therapy or occupational therapy or speech therapy, any of the modalities out there. The key for a nurse is to examine that patient and do a full head-to-toe assessment and help determine if a referral to another discipline, and by discipline I mean somebody like physical therapy, is appropriate. And when we determine that, we call the doctor and say, hey, we think that your patient could use a referral to physical therapy to work on these issues, such as pain and mobility.
And I think the same thing in a reverse would be true, Marco. When you as a physical therapist take your therapy into the home, you see that the patient, in some cases, probably cannot be cared for in the home and should go into a skilled rehab center.
Absolutely, yes.
But this is something that I think is one of the benefits of home nursing care. There's such a mix and match that can be done to make it more comfortable for people to receive the right kind of care. So how do you treat osteoarthritis, Marco?
Yeah, that's a great question. Well, and again, touching on the both sides of say, a joint replacement. Initially, well, the treatment generally involves a combination of exercise and and also lifestyle modifications, changes in lifestyle, like losing weight, for example. Okay. We, as home care therapists, we can treat the patient before a major event, like a joint replacement, and or after. Well, what happens is when osteoarthritic pain becomes unbearable, the treatment of choice, it's a joint replacement. Okay. And then what we do is we intervene after the joint replacement in a very effective way, treating the patient at home, helping them recovering for that major traumatic surgical event. What we do is we kind of bring the patient back to their environment little by little, trying to make sure that they get accustomed again to all the activities that are necessary for living. Like, say, for example, transferring, from a laying down position to a sitting position and then to standing position, right? That's a very simple thing that we do all the time. But after a joint replacement, that becomes quite difficult. We also gait train them. We train them again in ambulation, actually almost relearning how to walk, because now you have you have a metal joint per se, right? And you need to kind of relearn that correct way of ambulating. And then we also intervene in giving them exercises in order to strengthen that limb. Say your left knee was replaced, we need to re-strengthen your left lower extremity so you become more equalized again, so you don't walk with a limp per se. So that's pretty much where the treatment goes around.
Let's go back, all the way back to the first thing we talked about, osteoarthritis. So our viewers understand, and so make sure that I understand. If you get a diagnosis of osteoarthritis, therapy, medicines, there's not a cure for that, is there?
For joint replacement.
No, yeah.
Except for joint replacement.
Mm-hmm.
Yeah, which is not a cure, it's just a replacement.
Or you endure the pain.
Or you endure the pain.
Right. So let's go under the assumption that the person is diagnosed and they have to have a joint replacement.
Yes.
Now enter Gentiva Homecare. Mm-hmm. And this is a patient that wants to stay in their home. They don't want to go to a facility. Mm-hmm. What type of therapy, how do you do this in the home? What does Gentiva do in a home? Or any home health care, you happen to be Gentiva, but there are other organizations do the same thing. Absolutely. But I happen to like you because you all came to me and did me. And I recovered very successfully. Yeah, absolutely. I think.
Yes. Oh, absolutely.
Okay.
We did a beautiful job.
Absolutely. I think you did too. I did too. But what type of therapy do you do to help the patients, Marco?
Like I was trying to explain before, we are mainly coaches, right? Like you said, we rehabbed you very well. In reality, you rehabbed yourself very well. What we did was we served as your coach. We came to you and we told you, listen, in order to make sure that you don't derange this new joint, you need to move in this manner, right? We need to help you on transfers to begin with until point A to point B. And then we need to, like I said, we need to start ambulating again because you're going to use that. This is part of your life. It's probably the most functional activity that we perform during the day is to ambulate from the bed to the bathroom, from the bed to the kitchen, and vice versa, right? Or to the living room, right? So we bring you to, we bring the exercises necessary and the training that we've had to you as a coach. And what I say always to my patients is, we are here to show you how to do it, but who's going to perform your rehabilitation is yourself. So the more effort you put into it and the more compliance that you put into it, that will be only in your benefit. And at one point, we're going to say, Mr. Steckler, you have rehabbed yourself. You're now not ambulating with an assistive device, say, for example, a walker or a cane. Your range of motion of your knee has become functional again. You're able to go from point A to point B. The strength of your limb that was operated on is now within normal limits, and you're ready to go back to your normal life. So that's pretty much the guidelines where we kind of design our treatment to get you back to where you were or as close as you were before the surgery.
You want to add anything? Because I got something
I just want to say, I think Marco's selling what the physical therapists do a little bit short in that I agree with the goal is getting them back to where they were or as close, but in many cases, our physical therapists and our home PT program is able to make them better than they were prior to the joint replacement. Correct?
Exactly right.
Yes.
He's being a little
That's
modest.
right.
I mean, really, you know, the pain eventually subsides. There's a lot of pain with anything to do with bone surgery. But many times our patients fare better after surgery than they did prior. And their level of function and independence and, of course, quality of life increases.
Absolutely.
Let's just talk about it because have you had a hip replacement?
No, sir.
Have you had one?
No.
Knee?
No.
Knee?
Nope.
Okay. I have.
Have you?
I have, yes.
Tell us about that, Joe.
So, I know how bad it hurt before I made a decision, and I kicked myself for a long time for waiting to make the decision.
We hear that so much where
I know.
people say, why did I put that knee or that hip up? They're so afraid of the surgery, and a lot of times the pain that's involved post-surgical, and then once they are going through that recovery process and they see their pain subside, their independence increase, their mobility increase, I can't even tell you how many times we hear, why did I put this surgery off?
Yes.
Why didn't I do this sooner?
You know, the only problem from the time I came out, Dr. Robert Cooper did my surgery. The only problem I had was the night in the hospital after the surgery. I had so much gas that I thought I was going to die. The next day, the gas started to subside. A friend came over and helped Terry, my wife. They took me home. I don't even think I had a pain pill at home. My surgery went so well. I walked after that. I had no problems.
Yeah.
But I had a little problem in that maybe my hip I now had a little imbalance problem. So that's caused some problems, but I'm working through that.
Yeah, absolutely.
But I didn't have that agony of walking where the bone was on bone. And in thinking about that, and I before the show, I asked you all about a procedure called makoplasty. And what it actually is like a resurfacing of the bone, so that I think the goal is to prevent surgery or replacement of a joint if they can resurface this joint. And Marco, I think I'm right, but there are a couple of other new procedures out, and maybe you all could talk about that, where they're right now trying to. They've got some possibilities of putting that cushion, that membrane back in between the knee joints and the hip joints so that we don't have to go to such extremes with surgery. And this is what people need to know about. That's the purpose of what we're talking about.
Okay. Well, resurfacing has been a reality for a longer time. It is mainly a less invasive surgery than a joint replacement, where actually just the end surface of the bone is replaced, right? It's, like I said, less invasive. Your cut is a little bit less. There are benefits and there are some restrictions with that kind of surgery as well. It is a surgery that obviously takes a little bit less trauma to the patient. But in many cases, that is a preliminary kind of surgery where the patient does live with that for a while and then in the long run ends up needing a replacement. Not in every case. There's many cases where you can live with a resurfacing of your femur per se forever, and it's no problem. Makoplasty, as you indicated, it is an evolution of joint replacement. Mm-hmm. It is the physicians have been doing joint replacements for a long time, and now at this point we got to the era where a computer robot generated arm that actually guides where to avoid any misalignment of the joint. That's where makoplasty
right,
is.
exactly
That's exactly
right.
what it is. It's a joint replacement that is assisted by a computer-operated robot arm. That's what makoplasty is. It's the evolution of joint replacement. Like everything else in technology, we are evolving, and this is the next step.
Yeah, I had no idea what my replacement was going to look like or what it was, and I had a friend of mine that had a funeral parlor, so he gave me the ball and the arm that he had gotten from a cadaver, mm-hmm. and he said he gave it to me and said I could use it for a nutcracker.
There you go.
You're not smiling.
No, all right. If you want to do that. But you know what? Most joint replacement programs today, at least in this county, they have extensive classes that you can go to prior to that joint replacement where they teach the patient that and they show them what the what do I want to say? The prosthesis looks like, so that you can see that, so that you don't have to go to your friend that owns a funeral home and use a cadaver one. But they will show the patients this, and it's important because it's very, very hard. I know I'm a very visual person, and I can read all I want, and I can learn from that. But I really learn when you show me. And most, correct me if I'm wrong, our major hospital systems in this county, and there's not a lot of them, it's just really a couple. Both have excellent pre-joint replacement education programs to educate patients what that looks like, what to expect preoperatively, what to expect postoperatively, including pain. And quite frankly, a really good program will teach you that once that joint is replaced, barring any unforeseen circumstances, you're going to be put through the rigors after you get that joint replacement to get you up and moving.
The therapy part of it, yes. That was the next question I was going to ask. Talk about pre-surgical preparation. Actually, I think that the pre-surgical preparation, if we really wanted to admit it, is almost as important as the post part of it.
I would agree, because I would say that most of the time, the pre-education, correct me if I'm wrong, a lot of what's been taught with the anxiety doesn't sink in.
Oh, absolutely.
And then what does sink in is forgotten after surgery. So the more education that you can do ahead of time, the more few items that will stick in that patient's mind.
As you get older, and as much as we hate to admit it, I've been going, because of I have stenosis right now, and I have another problem. I haven't really figured it out, and I'm going to go to the guy that you want me to go to, Marcos. I'm going to do that. You've been very, very strong in making sure that I do this. And that's the beauty of having programs like this, folks, because we find out how we can help other people. But in the process of doing my therapy, when I was laying on my right side, the therapist had me do a motion with my left foot that was like this, and I could feel my hip drop. And the therapist watched me. I said, "That hurts." And she says, "Don't do that." I said, "What's happening?" She said, "Because you're getting older, the muscle on the outside of the hip does not have the same strength. Yes. And as much as they go to the gym and work out, ride a bicycle, everything, there are still other exercises that I could do that would be better, I would be better served. And that's what you do in therapy. That's what you do when you get in the home. You see the same thing. And there are exercises that you teach people in the home that they can do. They don't even think it is, because most of it is like the old Charles Atlas, the dynamic tension. But that's true, isn't it, Marco?
Absolutely. We target the muscles that are necessary for all your activities of daily living. And like the one that you refer to, which is your iliotibial band, right? The muscle on the side of your leg. It's very important to maintain a lateral balance of your pelvis and everything else. It's just things that we, obviously, the lay population, it's not, educated on, and that's what we go to school for. We absolutely hone in the points where we know are going to be problems after the replacement, or even before the replacement as well, because with osteoarthritis, there's many cases where because of the lack of activity and the lack of range of motion, you start actually having some atrophy of muscles that command that joint. So that's pretty much what happened with you. Your ITB, your iliotibial band, needed some strengthening, some specific strengthening to make sure that you can walk in a straight line, and you don't have any shifting of your pelvis when you ambulate, and you don't have even more derangement with that.
But we're going to do a show on balance with Chris Marriott that runs your Safe Strides program. And all these things are connected together. And let's go back to the original topic of our show, osteoarthritis. Mm-hmm. As a registered nurse, Nancy, and you, Marco, as a therapist, what can our viewers do to help them recognize that they might be having osteoarthritis? And if they think they have it, what courses of action should they take?
Well, I'll start out by saying most older Americans have a degree, at least, of osteoarthritis. And I'm going to default to Marco to talk about what you do pre-surgically. We've talked about the surgeries enough.
Right.
But I'm going to default to Marco to talk about what you can do if surgery is not an option, or if surgery is not an option in the near future.
Absolutely. The numbers are astounding. 27 million people in the United States suffer of osteoarthritis.
27 million?
Yes, at this point. And upon x-rays, about 80% of the population over 65 years old show signs of osteoarthritic joints. So numbers are pretty huge. Conservative treatment, which is pre-joint replacement, has to do with a lot of lifestyle modification. Weight loss is very important. Unfortunately, a lot of our population suffer of osteoarthritic symptoms that are exacerbated by extra weight.
Right, I agree.
Also, patient education and self-management is something very important when you start having the symptoms. Exercise in moderation is a great way of trying to prevent the fast progress of the disease, but it is something that also patients need to understand that moderation is a very important issue. A lot of people that start engaging in an exercise program, they exaggerate, and they actually furthermore progress their issue, their osteoarthritic problem. So mainly what we do is, say for example, if you do have a patient that has been diagnosed with osteoarthritis, and you receive them in a preoperatively way, in a conservative way, if you will. If the doctor refers the patient to a physical therapist for osteoarthritic problems, what we do is we concentrate on that area of the patient, and we do strengthening exercises in order to maintain stability of that joint. So say, for example, is your knee, and you have an osteoarthritic knee. What we do is we start actually trying to strengthen the muscles and ligaments around that knee in order to maintain that knee stable, right? Because instability, we know that when you have a joint that actually travels too much beyond its limits, that produces some shearing of that cartilage, and that just progresses the joint even, the osteoarthritis even more. So it's mainly a strengthening program, and in many cases, like I was saying, in lifestyle modification, what we try to do is to kind of change the mind of the patient in order to make them understand that exercise has to do with discipline and consistency, meaning that you can't do exercise for a week and then stop for 3 months, and then do it for a week and stop for 3 months.
Or, like the therapist finally beat into me, since I love to work out every day, you can't do the same exercise on the same part of the body and overextend that exercise day after day. You've got to give it a chance to heal.
Yes, sir.
And you know, for a person that's an athlete and is used to working out and playing football and getting beat up and everything, it was hard for me to accept the fact that I couldn't keep punishing my own body and making it heal.
Yeah. Lots of factors that involve in healthy exercise programs. You have to have hydration, nutrition, stretching, strengthening, resting. All of these factors are very important. So that's why you have professionals of our area that actually kind of design that program, and bear in mind that every person is different. So we need to design that program, kind of customize that program in a way that you know that it's going to be beneficial to the patients.
Mm-hmm. I think a proper consultation with a physical therapist is of utmost importance, because every individual is going to be to be different, and what their plan is.
Absolutely.
Yeah. And what you're both have said, just echo what I have heard stated by good therapists. There are therapists, and then there are therapists, and it's just like in any field in life. Some people really know what they're doing, and some have got a decent appreciation. So I think one of the biggest things, Marco, in therapy for osteoarthritis or any other joint problem, if you go to a good therapist, you can sort of feel you're going to get better treatment. We got about 1 minute. Either one of you got a comment that you want to make about the cervical osteoarthritis or what we should do?
I just want to stress even more that exercise and lifestyle modification is very important in order to prevent and even to improve your osteoarthritic issue. Like I said, many things enter the equation. You need to make sure that they are all balanced, that you do have good hydration, good nutrition, that you do it in moderation, that you have consistency and discipline. And that's about it. I mean, you need to make sure that is balanced.
That's good. We're out of time. I want to thank you both for being here today. But thank you, viewer, for watching today's episode of Focus on Seniors. If you have questions or comments, you can call radio station WMEL AM 1300 at 321-631-1300. For more information on senior care and resources, visit our website, helpingseniorsofbrevard.com. Thank you for watching today's show, and I hope it's been informative to you.